Assalamu alaikum. I would like to thank the organizing committee for inviting me to talk about calcaneal fractures and to be among this awesome gathering today. Displaced intraarticular calcaneal fractures, how to get it right first time. I have nothing to disclose related to my talk. This topic, as I think, is the intraarticular calcaneal fractures is an unanswered question till now, and the literature almost shows operative treatment have the same results like non-operative treatment, and the best available evidence are randomized controlled trials. The most famous is the Canadian trial by Buckley, 2022, and the Swedish trial, 2013, UK Hill Trial 1, UK Hill Trial 2. All of them show the same results comparing the operative and non-operative treatment. But there is consensus that perfect reduction has a better patient-reported outcomes. Also, there is higher relative risk of subtalar fusion in the non-operatively treated cases, with difficulty in achieving reconstruction of the malaligned and malunited hind foot in intraarticular calcaneal fractures. But there is absolute indication for open reduction internal fixations, which are almost excluded from the UK Hill trial, like this displaced tongue type fractures with soft tissue compromise. You cannot think either operative or non-operative because the skin will immediately slough. In cases of open fractures, transcalcaneal talonavicular fracture dislocations with bad injury. The talonavicular dislocation fracture, so the talus is dislocated through the calcaneus, and fracture dislocations where the superior lateral fragment is dislocated lateral to the fibular head. The worst scenario is OIF, is to choose to do open reduction and the internal fixation, but you fail to achieve satisfactory reduction and restoration of the external dimensions of the calcaneus. And like in this scenario, the patient got open reduction, internal fixation, the alignment of the hind foot is not restored, the articular surface is not restored, and the patient developed osteomyelitis of the calcaneus. The patient gained the benefit, the patient got the complications of surgery and the disadvantages of non-operative treatment. Another case, the patient has subfibular impingement with lateral wall blowout, with peroneal tendonitis, prominent screws, no articular reductions. The talar declination angle is not restored. The patient has anterior ankle impingement, lateral ankle impingement, difficulty with shoe wear. In Faronia Hospital, since 2013, we started doing minimally invasive sinus tarsi approach for intraarticular calcaneal fractures. And this is the position we used for our surgery in lateral decubitus. Before dropping, we start to teach the patient, the AC-arm technician, how to take lateral view, how to take the axial view, how to take prudence view. And this is aided by the use of headlight. This makes the job easier after covering the patient because the C-arm technician will be confused after covering. This is a case example. This patient is 41 years old. He fell from a scaffold and he sustained displaced intraarticular calcaneal fractures with diminished calcaneal height, lateral wall blowout. And this is CT scan. The superlateral fragment is almost abutting the plantar surface of the calcaneus. The secondary fracture line is extending to the calcaneocuboid joint. And there is also fracture line into the syntacculum, the constant fragment. Before starting the surgery, this is CC-arm taking before surgery. We used to put this tractor before opening a sinus tarsi approach. You put one calcaneal pin in the most posterior aspect of the calcaneal tuberosity, perpendicular to the malaligned calcaneal tuberosity, and the other pin in the distal anterior aspect of the tibia, just above the ankle joint. We start this traction to push the calcaneal tuberosity distally, posteriorly, and plantarly. This is after distraction. the calcaneal tuberosity is pushed down. The medial wall still there is a step after destruction and restoration of the length, but the calcaneal the varus in intraarticular calcaneal fractures compose two deformities: the varus position of the heel and lateral translation. This is after destruction. Then we start to push the calcaneal tuberosity over the smooth spin medially to restore the medial calcaneal wall. And at this stage, we put two wires from the calcaneal tuberosity to the substentacular fragment or the constant fragment, keeping the depressed part in the middle of the calcaneus away from our fixation, because we will manipulate it after we open sinus tarsi approach. The distractor can be either medial or medial and lateral and do differential distraction. I do both according to the availability of the open compressor device. This is a sinus tarsi approach marked in the skin from the tip of the fibula into the direction of the fourth metatarsal base. This is the intraoperative photo of the after we open the sinus tarsi approach with using the head light source. This is after we reduce the articular fragment or the superior lateral fragment to the substentacular fragment with the calcaneal tuberosity pushed away distally and backward, and the anterior process is reduced, and all are fixed by percutaneous wires. My advice is not to trust the lateral view of the calcaneus to assess the quality of your reduction. The best thing is to go through the 4 degrees of Broden's view to see if there is an articular step, because the superlateral fragment is almost always rotated and depressed. If you elevate it without derotating it, you will get step, especially in the posterior part, which is clear, and the 4-degree angle of the Broden's view, which is difficult to see by your eye, even using the headlight, because it is immediately medial to the peroneal tendons behind the fibula. This is the 2nd degree of 20 degree of Broden's view, 30 degree, and 40 degree and lateral view. Now we are sure the articular surface is reduced, temporarily fixed by Q wires. We'll start the definitive fixation using the same wires for definitive fixation by cannulated screws, fully threaded. There is no place for leg screw because we need to keep the position we achieved. The strategy of our screws is 1 screw from the calcaneal tuberosity to the, or 2, even according to the size of the fragment, from the calcaneal tuberosity to the substentacular fragment, from the calcaneal tuberosity to the anterior process. In addition to key wires, if sometimes we have small anterolateral fragment from the anterior process, which is not, I find difficult to put screws through it. The most important thing is the transverse screws from the superior lateral fragment into the substentacular, which is technically, even in my hand, I feel it is challenging to target exactly this small piece of bone, which is the most dense, and you depend on it for your construct. After fixation by cannulated screws, I remove the wires. Here I keep 2 wires holding small fragments, which are not candidate for 3.5 screws. This is a case example. This patient is a construction worker. He fell from a scaffold and he sustained displaced intraarticular calcaneal fracture. The CT scan showed this is Sander type 3, and the middle fragment is fractured in the coronal plane, anterior part and the posterior part. In these cases, I found a challenge to reduce it through the sinus tarsi approach. I take the breast fragments outside and I construct it on the table, and I use fully threaded 1.2 key wires to reconstruct it in subcondylar bone to keep space for the definitive fixation. This is the picture after reduction. Here, this picture is hazy. This is after reduction through the sinus tarsi approach. With the upper part is the calcaneal, the talar tuberosity, talar tubercle. This one. This is the lateral fracture of Sander classification, and this is the medial one, and this is the fluorogestion angle. This is the best cortical read. And this is the immediate post X-ray, and the polar angle is restored to 33 degrees. This is a missed wire, the fully threaded wires I used to reconstruct the articular surface outside the field. And this is the result after 4 years. I try to contact the patient sometimes because of financial problems. They refuse to come and reveal the X-ray. The patient I asked the patient about he returned back to work or not. He sent to me his picture while he's in a scaffold. He returned back to his work. The second case, this patient is 31 years old. He fell also from a scaffold and he has bilateral displaced intraarticular calcaneal fractures, joint depression type. This is the axial view, both sides. And this is the immediate post-X-ray. And this is the long-term results after 3 years. This is the axial view, both sides. And this is the patient gait after 3.5 years. This man is 45 years. He's a taxi driver, and he survived an RTA and developed badly displaced joint depression type intraarticular calcaneal fractures with the posterior facet completely displaced medially, pressing on the neurovascular bundle. We shift the patient immediately. We couldn't feel the distal pulse, but the capillary filling was okay. We shift the patient from the casualty to CT scan and to the OR. This is CT scan. And this is a reduction achieved using the distractor and sinus terci approach. And this is the side of the incision, about 4 centimeters. And this is the results comparing to the other side. The dimensions of the calcaneus is almost restored. The osteoarthritis is inevitable with this high energy trauma, but the patient is happy with the results. He's returned back to his work. And this is his gait. The last case, this patient is 21 years old male. He jumped from somewhere, I don't know the exact history, he denied the true history, and he developed bilateral tongue-type fractures, badly displaced on the right side with blunter fragment. And this is a bilateral axial view. And this X-ray taken 140 days. I calculated the dates from the dates registered by the HIS system on the X-ray. And this is his gait. 140 days. And he traveled to Saudi Arabia and didn't see him back, just chatting through Facebook. He jumped. Yes. He was in Ward 21. Yes. Take home message. Sinus terci approach. Through sinus terci approach, you can achieve anatomical reduction as the extended lateral approach for calcaneal fractures. But in addition, but the advantage is we can minimize the soft tissue complications. We have in Farani Hospital we have 0% infection rate in minimally invasive management of calcaneal fractures. The other advantage is we can do definitive surgery on day 1. No need to wait for a wrinkle sign or improvement of soft tissue condition. The use of distractor, I call it tireless assistant hand. You can use it to push the calcaneal tuberosity wherever you want and keep it until you put your preliminary fixation and then definitive fixation. It is a powerful reduction tool to restore the external calcaneal dimensions, which is essential in management of calcaneal fractures. As we all know, we need to restore the articular reduction, anatomical articular reduction, restoration of the external calcaneal dimension like the calcaneal length, calcaneal height, Bowler's angle, which has a prognostic significance. But over reduction during distraction, I don't have any tool how to judge it, because especially if the patient has bilateral fractures. Even in unilateral, during distraction, it is roughly done. I don't know how to gauge it. intraoperatively. I think we are still in need for robust evidence, like randomized controlled trial to compare operative and non-operative treatment, comparing well-matched cohorts of patients to reach definitive conclusion and to avoid or to correct the deficiencies or the flaws in the available literature till now. Thank you for attention. Last slide.
Thank you.
Thank you.
Thank you, Dr. Mtwali. So do we have any questions for Dr. Mtwali in his talk?
Okay, thank you for your lecture. I want to know what is the rule for blade fixation for these fractures? I think you always move the screws. What about the blades? And what about bone grafting? Do you need bone grafting for these fractures?
Regarding the first question, I have no experience in using blades through the sinus tarsi approach. I only used cannulated screws in addition to key wires, plus or minus key wires. But I have no experience in using blades, and I think there's special blades for this, like Tournier blade, and which we don't have. But I am happy with doing only screws. Regarding the second question, I used graft only. The last graft I used was in 2013 through the extensile lateral approach, and the patient developed infection, and since that date I didn't use it at all. And all these defects fill with time. After distraction, there is a big cavity in the calcaneus. All of them during long-term follow-up fill with cancellous bone, but I didn't use graft at all.
Okay, any other question?
Excellent cases, Doctor. Just a question. When do you decide on doing an acute hindfoot fusion?
To be honest, I didn't try it. I kept it for Dr. Abdel Salam. He's doing primary fusion for Sander type 4 and comminuted calcaneal fractures. But me, I didn't try it till now.
Doctor, I noticed in some X-ray you have fully threaded K wires. Or is that an artifact?
No, it's an artifact. I use the fully threaded wires for reconstruction of the articular fragments only. To change it from Sander 3 to Sander 2.
From where we can get this wires? We don't have it in our hospital.
This is from Kuwait.
From Kuwait?
Yes.
Fully threaded K wire.
But now it's not available. We used to borrow it from Razi Hospital.
Dr. Mtwali, thank you for this nice cases. Our aim in calcaneal fracture to restore the lens and varus and the articular step off, okay?
Yes.
The point is you usually use the percutaneous technique, and this is accepted nowadays to avoid skin complication. But my point is, what is the size of screws you use it? 6.5, 7, 7.3?
4.5 cannulated screws, in addition to 3.5 for the transverse screws.
I think
in a lag fashion.
This is small. You can use larger diameter to take a big room.
I think to use 6.5 cannulated screws, the head is difficult to even by force you cannot borrow it.
You can sink it. Another question is, I saw some screws coming from up down and screws from down up. The coming from down up, this will be potentially penetrate the joint. You have articular surface. I'm afraid from this also, the screw coming from up down, it will be painful for the plantar fascia, either medial or lateral plantar fascia. Usually, I prefer to do a parallel screw as support, and then from the sinus tarsi, small screw like 3.5 to support the articular reduction.
Regarding the use of the head of the screws, I don't go through bluntly. Not from the blunter aspect of the heel, I go posterior inferior. It is away from the weight bearing area. Sorry? Into the joint? No. The configuration of the posterior facet is saddle shaped. The most inferior part is medially. I used to confirm the articular reduction and the position of the screw with my eyes using the headlight and through prudence view. But regarding the head of the screw and the size of the cannulated screws, I never used 6.5, and I have only one case fractured, the broken screw, the cannulated one. Oh, but this was badly displaced. The fracture was huge defect plantarly, and the patient most probably bought weight early. Only one case, broken screws.
Okay.